About chapter 15, psychological disorders. In the old days weren't that long ago, only about 25 years ago. The total focus of psychology was on abnormal behavior. Now we try to support positive psychology. We try to support people getting better, people doing things to make them resilient. But we still have to focus on the people with the problems, and those are the psychological disorders. That's the DSM-5 and whatnot. If you've been watching the news lately, they caught the Gilgo Beach serial killer. He killed as many as 11 people. Most of them were sex workers, female sex workers that he dismembered and wrapped in burlap sacks and carried to a remote area of the Gilgo Beach National Park. And he lived right there. And people thought, well, he's a really nice guy, a really nice guy. I really like him. Then, of course, psychologists weighed in and went, yeah, the whole anti social personality disorder thing can come into play here, and they act one way and they are actually another way. I was really kind of interesting. I was reading about the individual that they caught, and they were saying that he compartmentalizes. So when he's the serial killer, he acts in a certain way, and when he is not the serial killer, when he's not killing people, he acted a totally different way. But there were, of course, you can't always not act like this person. So there were indicators, that there were triggers that he used. Anyways, okay, so let's go ahead and get into this chapter. It's a fascinating chapter. You don't have to care about the Gilgo Beach serial killer. That's way over in on Long Island, New York City. Anyway, psychological disorder is a condition characterized by abnormal thoughts, feelings, and behaviors. Psychopathology is the study of psychological disorders, including their symptoms, etiology, in other words, their causes, and their treatment. The term psychopathology can also refer to the manifestation of a psychological disorder. Although consensus can be difficult, it is extremely important for mental health professionals to agree on what kinds of thoughts, feelings, and behaviors are truly abnormal in the sense that they genuinely indicate the presence of psychopathology. Certain patterns of behavior and inner experience can easily be labeled as abnormal and clearly signify some kind of psychological disturbance. A person who washes their hands 40 times a day and a person who claims to hear voices of demons exhibit behavior and inner experiences that most would regard as abnormal, beliefs and behaviors that suggest the existence of a psychological disorder. It's not normal to wash your hands 40 times a day or to hear voices of demons. Perhaps the simplest approach to conceptualizing psychological disorders is to label behaviors, thoughts, and inner experiences that are atypical, distressful, dysfunctional, and sometimes even dangerous as signs of a disorder. Wakefield in 1992 defined psychological disorder as a harmful dysfunction. Wakefield argued that natural internal mechanisms, psychological processes honed by evolution, such as cognition, perception, and learning, have important functions such as enabling us to experience the world the way others do and to engage in rational thought, problem solving, and communication. Learning allows us to associate a fear with a potential danger in such a way that the intensity of fear is roughly equal to the degree of actual danger. Dysfunction occurs when an internal mechanism breaks down and can no longer perform its normal function. But the presence of a dysfunction by itself does not determine a disorder. The dysfunction must be harmful in that it leads to negative consequences for the individual or for others, as judged by the standards of the individual's culture. The harm may include significant internal anguish, for example, high levels of anxiety or depression, or problems in day-to-day living in one's social or work life. There are significant disturbances in thoughts, feelings, and behaviors. And this is according to the psychological disorder, the APA. There's two APAs, as strange as that may seem. There's the American Psychological Association, and they're the ones that publish all of the articles and journals that deal with psychological disorders. And then there's the American Psychiatric Association, and they're the ones that publish the DSMs. They are the ones that have always published the DSMs. Right now we're on DSM-5 TR. I have a copy of it over there. It's turquoise blue. It's a metallic turquoise blue. So if yeah, so I've got it. The person must experience inner states, for example, thoughts and feelings, and exhibit behaviors that are clearly disturbed, that is unusual, but in a negative, self-defeating way. Often such disturbances are troubling to those around the individual who experiences them. Disturbances reflect some kind of biological, psychological, or developmental dysfunction. Disturbed patterns of inner experiences and behavior should reflect some flaw or dysfunction in the internal biological, psychological, and developmental mechanisms that lead to normal, healthy psychological functioning. The disturbances lead to significant distress or disability in one's life. A person's inner experiences and behaviors are considered to reflect a psychological disorder if they cause the person considerable distress or greatly impair his ability to function as a normal individual, often referred to as functional impairment or occupational and social impairment. And of course, that's one of the interesting things about the Gilgo Beach serial killer is that he was an architect, and it didn't bother him at all. They finally caught him. That was interesting, but it didn't cause any distress or disability in his life at all. The disturbances do not reflect expected or culturally approved responses to certain events. Disturbances in thoughts, feelings, and behaviors must be socially unacceptable responses to certain events that often happen in life. Arriving at a proper diagnosis, that is, appropriately identifying and labeling a set of defined symptoms, is absolutely crucial. This process enables professionals to use a common language with others in the field and aids in communication about the disorder with the patient, colleagues, and the public. A proper diagnosis is an essential element to guide proper and successful treatment. For these reasons, classification systems that organize psychological disorders systematically are necessary. And now we're going to talk about the DSM-5. There we go, DSM-5. And they, like I said, they just came out with a new one, the DSM-5 TR. I think it's a TR. Wait a minute, let me take a look. Yeah, the TR. I have a copy of the DSM-5 as well. It was a purple book. Always comes out in a certain color. I also have the DSM-4 TR, which is silver, as exciting as that is. A number of classification systems have been developed over the years. The one that is used by most mental health professionals in the United States is the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, published by the American Psychiatric Association in 2013. The first edition of the DSM, published in 1952, classified psychological disorders according to a format developed by the U.S. Army during World War II. And that's according to Clegg in 2012. The DSM-5 includes many categories of disorders, so for example, anxiety disorders, depressive disorders, and dissociative disorders. Each disorder is described in detail, including an overview of the disorder, diagnostic features, specific symptoms required for diagnosis, diagnostic criteria, Prevalence information, what percent of the population is thought to be afflicted with the disorder, and risk factors associated with the disorder. The DSM-5 provides information about comorbidity, the co-occurrence of two disorders at the same time. 41% of people with obsessive-compulsive disorder, OCD, also meet the diagnostic criteria for major depressive disorder. Drug use is highly comorbid with other mental illnesses. 6 out of 10 people who have a substance use disorder also suffer from another form of mental illness, usually anxiety or depression, as interesting as that is. The DSM has changed considerably in the half-century since it was originally published. The first 2 editions of the DSM listed homosexuality as a disorder. However, in 1973, the APA voted to remove it from the manual, and it won by 1 vote. They took it out by 1 vote, and that's according to Silverstein in 2009. And these are what color they are. There's a DSM. This is 1. This is 2. This is 3, and this is 3 revised. And as you can see, they keep changing colors. The new one is kind of this color, except it's metallic. While DSM-3 did not list homosexuality as a disorder, it introduced a new diagnosis, ego-dystonic homosexuality. In 1986, the diagnosis was removed from the DSM-3R, and that's according to Herrick in 2012. There we go. There's the DSM-4 and the DSM-4TR. Beginning with the DSM-3 in 1980, mental disorders have been described in much greater detail, and the number of diagnosable conditions has grown steadily, as has the size of the manual itself. The DSM-1 included 106 diagnoses and was 130 total pages, whereas the DSM-3 included more than 2 times as many diagnoses, 265, and was nearly 7 times its size, 886 total pages. The DSM-5 includes only 237 disorders, a decrease from 297 disorders that were listed in the DSM-4. The DSM-5 includes revisions in the organization and naming of categories and the diagnostic criteria for various disorders, while emphasizing careful consideration of the importance of gender and cultural difference in the expression of various symptoms. A second classification system, the International Classification of Diseases, the ICD, is widely recognized. It was published by the World Health Organization. The ICD was developed in Europe shortly after World War II and has been revised several times. The categories of psychological disorders in both the DSM and the ICD are similar, as are the criteria for specific disorders, though some differences exist. The ICD is used for clinical purposes and to examine the general health of populations and to monitor the prevalence of diseases and other health problems internationally. The ICD is in its 10th edition, the ICD-10. And when I was working in medicine, and this was about 25 years ago, we were using the ICD-9. So it seems a little odd to me to say ICD-10 since I was working on the ICD-9. Remember that psychological disorders represent extremes of inner experience and behavior. Each of us experiences episodes of sadness, anxiety, and the preoccupation with certain thoughts, times when we do not quite feel ourselves. People with psychological disorders are far more than just embodiments of their disorders. It is important to remember that a psychological disorder is not what a person is. It is something that a person has, usually through no fault of their own. That's a lot of hair. For centuries, psychological disorders were viewed from a supernatural perspective, attributed to a force beyond scientific understanding. Those afflicted were thought to be practitioners of black magic or possessed by spirits. Convents throughout Europe in the 16th and 17th centuries reported hundreds of nuns falling into a state of frenzy in which the afflicted foamed at the mouth, screamed and convulsed, sexually propositioned priests, and confessed to having carnal relations with devils or Christ. Although today these cases would suggest serious mental illness, at the time these events were routinely explained as possession by devilish forces. The biological perspective views psychological disorders as linked to biological phenomena such as genetic factors, chemical imbalances, and brain abnormalities. It has gained considerable attention and acceptance in recent decades. Evidence from many sources indicates that most psychological disorders have a genetic component. In fact, there is little dispute that some disorders are largely due to genetic factors. And two examples of that would be schizophrenia and autism spectrum disorder. Oh, this is schizophrenia. Shows you the connection. Only 1% of the population has it. If your first cousin has it, you have a 2% chance of getting it. If you have an aunt and uncle, 2%. Nephews and nieces of yours, 4%. Grandchildren, 5%. Half siblings, 6%. Parents, 6%. Siblings, 9%. Identical twin has it, 48% chance of having schizophrenia. The diathesis stress model integrates biological and psychosocial factors to predict the likelihood of a disorder. This diathesis stress model suggests that people with an underlying predisposition for a disorder, a diathesis, are more likely than others to develop a disorder when faced with adverse environmental or psychological events such as stress, such as childhood maltreatment, negative life events, trauma, and so on. A diathesis is not always a biological vulnerability to an illness. Some diatheses may be psychological, a tendency to think about life events in a pessimistic, self-defeating way. The key assumption of the diathesis stress model is that both factors, diathesis and stress, are necessary in the development of a disorder. Different models explore the relationship between the two factors. The level of stress needed to produce the disorder is inversely proportional to the level of diathesis. Anxiety disorders are characterized by excessive and persistent fear and anxiety and by related disturbances in behavior. Although anxiety is universally experienced, anxiety disorders cause considerable distress. As a group, anxiety disorders are common. Approximately 25% to 30% of the U.S. population meets a criteria for at least... What are you chewing on? My dog's chewing on something strange. Oh, a piece of plastic. As a group, anxiety disorders are common. 25 to 30% of the U.S. population meets a criteria for at least one anxiety disorder during their lifetime. These disorders appear to be much more common in women than they are in men. Within a 12-month period, around 23% of women and 14% of men will experience at least one anxiety disorder. Anxiety disorders are the most frequently occurring class of mental disorders and are often comorbid with each other and with other mental disorders. Phobia is a Greek word that means fear. A person diagnosed with a specific phobia experiences excessive distressing and persistent fear of anxiety about a specific object or situation, such as animals, enclosed spaces, elevators, or flying. For an example of a phobia would be my brother, who is afraid of snakes, deathly afraid of snakes. If he sees a snake, he goes the other way, no matter what kind of a snake it is. I have no idea why, because he's never lived any place where they had poisonous snakes. So that's a little strange. But I've lived in Montana. I actually have interacted with 5 rattlesnakes. 2 that, one bit my dog and 1 bit my horse, or my wife's horse actually, so that wasn't mine, and almost killed them, both of them. We had to take them both to the vet. Luckily, we were able to save them. I was surprised. Even though people realize their level of fear and anxiety in relation to the phobic stimulus is irrational, some people with a specific phobia may go to great lengths to avoid the phobic stimulus, the object of, or situation that triggers the fear and anxiety. Typically, the fear and anxiety a phobic stimulus elicits is disruptive to the person's life. Specific phobias are common. In the United States, around 12.5% of the population will meet the criteria for a specific phobia at some point in their lifetime. Okay, here you go. What are people the most afraid of by state? I'm from Indiana. My greatest fear is being alone. Here I'm living in Iowa. My greatest fear is people. Living in Iowa. I've also lived in Oklahoma, and that their greatest fear is flying. I've lived in Texas, and that's the outside, their fear of outside. And I'll have to admit, when I lived in Texas, you'd drive around and there'd be all these nice houses and they'd have stuff outside, and you would never see any people. As weird as that is, I lived in Ohio, and they have the great fear of needles. Social media is a great fear in California. I've lived there twice. I lived in Montana, where clowns are the thing that people are afraid of. Maryland. I've lived in Maryland. It looks like fear of flying, I'm thinking, or holes. That's a little weird. Where else have I lived? Mississippi, fear of people. Montana, Nebraska, public speaking. There you go. You can't argue with that one. Where else have I lived? In the United States, I mean. That's enough, I guess. Fear of heights in Hawaii. That makes sense. There's nothing tall in Hawaii. Arachnophobia is the fear of spiders and other arachnids. One of the most common explanations for this and similar animal phobias is that such creatures once posed a considerable threat to our ancestors, so it's instinctual. Ophidiophobia is the fear of snakes. This phobia is quite common and often attributed to evolutionary causes, personal experiences, or cultural influences. Some suggest that since snakes are sometimes poisonous, our ancestors who avoided such dangers were more likely to survive and pass down their genes, and this, of course, is a rattlesnake. A diamondback. Acrophobia, or the fear of heights, impacts more than 6% of people. This fear can lead to anxiety attacks and avoidance of high places. This fear may have evolved as an adaptation to an environment in which a fall from heights posed a significant danger. Aerophobia, or fear of flying, affects between 10% and 40% of U.S. adults, despite the fact that airplane accidents are actually very uncommon. Around 1 out of every 3 people have some level of fear of flying. Cynophobia, or these are the 10 most common phobias in the United States. Cynophobia, or the fear of dogs, is often associated with specific personal experiences, such as being bitten by a dog during childhood. Such events can be quite traumatic and can lead to fear responses that last well into adulthood. This particular phobia can be quite common. Astrophobia is a fear of thunder and lightning. People with this phobia experience overwhelming feelings of fear when they encounter such weather-related phenomena. Symptoms of astrophobia are often similar to those of other phobias and include shaking, rapid heart rate, and increased respiration. Trypanophobia is the fear of injections, a condition that can sometimes cause people to avoid medical treatments and doctors. Like many phobias, this fear often goes untreated because people avoid the triggering object and situation. Estimates suggest that as many as 20% to 30% of adults are affected by this type of phobia, trypanophobia. Mysophobia, or the excessive fear of germs and dirt, can lead people to engage in extreme cleaning, compulsive hand washing, and even avoidance of things or situations perceived as dirty. In some instances, this phobia may be related to obsessive compulsive disorder. Claustrophobia, the fear of enclosed spaces. People with this fear say that they feel like the walls are closing on them. Some theories suggest that it's a genetic link to specific phobia as a kind of dormant survival mechanism. And you wouldn't want to, if you had claustrophobia, you wouldn't want to live where I am. we've got we've got cornfields to the north and the south of us, and the corn's about 15 feet tall right now. So if you have any claustrophobic ideas, you can't see the road in the trees. They're starting to get taller than the trees. Autophobia or monophobia is the fear of being alone or lonely. Being alone, even in a usually comforting place like home, can result in severe anxiety for people with this condition. People with autophobia feel they need another person or other people around in order to feel safe. Agoraphobia is listed in the DSM-5 as a separate anxiety disorder. Agoraphobia, which literally means fear of the marketplace, is characterized by intense fear, anxiety, and avoidance of situations in which it might be difficult to escape or receive help if one experiences symptoms of a panic attack, a state of extreme anxiety that we will discuss shortly. These situations include public transportation, open spaces like parking lots, enclosed spaces like stores, crowds, or being outside the home alone. About 1.4% of Americans experience agoraphobia during their lifetime. And when I was working up on the Fort Belknap Reservation, the psychiatrist that would come and work with people on the reservation said this is the most common problem that people had. She thought it might have something to do with their fear of white people, because the people in Montana aren't all that. The white people in Montana aren't all that friendly, and I'm a scary guy. Well, not really. Rockman in 1977 proposed that phobias can be acquired through three major learning pathways. The first pathway is through classical conditioning. A child who has been bitten by a dog may come to fear dogs because of a past association with pain. The second pathway of phobia acquisition is through vicarious learning as modeling. A child who observes his cousin react fearfully to spiders may later express the same fears, even though spiders have never presented any danger to him. The third pathway is through verbal transmission or information. A child whose parents, siblings, friends, and classmates constantly tell her how disgusting and dangerous snakes are may come to acquire a fear of snakes. Social anxiety disorder, formerly called social phobia, is characterized by extreme and persistent fear or anxiety and avoidance of social situations in which the person could potentially be evaluated negatively by others. As with the specific phobias, social anxiety disorder is common in the United States. A little over 12% of all Americans experience social anxiety disorder during their lifetime. The heart of the fear and anxiety in social anxiety disorder is the person's concern that he may act in a humiliating or embarrassing way, such as appearing foolish, showing symptoms of anxiety like blushing, or doing or saying something that might lead to rejection, such as offending others. The kinds of social situations in which individuals with social anxiety disorder usually have problems include public speaking, having a conversation, meeting strangers, eating in restaurants, and in some cases using public restrooms. When people with social anxiety disorder are unable to avoid situations that provoke anxiety, they typically perform safety behaviors, mental or behavioral acts that reduce anxiety in social situations by reducing the chance of negative social outcomes. Safety behaviors include avoiding eye contact, rehearsing sentences before speaking, talking only briefly, and not talking about oneself. Other examples of safety behaviors include assuming roles in social situations that minimize interactions with others, like taking pictures, setting up equipment, or helping prepare food, asking people many questions to keep the focus off of oneself, selecting a position to avoid scrutiny or contact with others, sitting in the back of the room, wearing bland, neutral clothes to avoid drawing attention to oneself, and avoiding substances or activities that might cause anxiety symptoms such as caffeine, and that's misspelled, warm clothing, and physical exercise. People with social anxiety disorder may resort to self-medication such as drinking alcohol as a means to avert the anxiety symptoms they experience in social situations. The use of alcohol when faced with social situations may become negatively reinforcing, encouraging individuals with social anxiety disorder to turn to the substance whenever they experience anxiety symptoms. There's always the danger of comorbid social anxiety disorder and alcohol use disorder. As with the specific phobias, it is highly probable that the fears inherent to social anxiety disorder can develop through conditioning experiences. For example, a child who is subjected to early unpleasant social experiences, like bullying at school, may develop negative social images of themselves that become activated later in anxiety-provoking situations. One study reported that 92% of a sample of adults with social anxiety disorder reported a history of severe teasing in childhood, compared to only 35% of the sample of adults with panic disorder. One of the most well-established risk factors for developing social anxiety disorder is behavioral inhibition. Behavioral inhibition is thought to be an inherited trait, and it is characterized by a consistent tendency to show fear and restraint when presented with unfamiliar people or situations. Behavioral inhibition is displayed very early in life. Behaviorally inhibited toddlers and children respond with great caution and restraint in unfamiliar situations, and they're often timid, fearful, and shy around unfamiliar people. Behavioral inhibition has been associated with more than a 7-fold increase in the risk of development of social anxiety disorder. Behavioral inhibition is a major risk factor for the disorder. People with panic disorder experience recurrent more than one and unexpected panic attacks, along with at least 1 month of persistent concern about additional panic attacks, worry over the consequences of the attacks, or self-defeating changes in behavior related to the attacks, for example, avoidance of exercise or unfamiliar situations. A panic attack is defined as a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. Its symptoms include accelerated heart rate, sweating, trembling, choking sensations, hot flashes or chills, dizziness or lightheadedness, fears of losing control or going crazy, and fears of dying. Sometimes panic attacks are expected occurring in response to specific environmental triggers. Other times, these episodes are unexpected and emerge randomly. Experiencing a panic attack is also often terrifying. Rather than recognizing the symptoms of a panic attack merely as signs of an intense anxiety, individuals with panic disorder often misinterpret them as a sign that something is intensely wrong internally. Panic attacks can occasionally precipitate trips to the emergency room because several symptoms of panic attacks are, in fact, similar to those associated with heart problems. For example, palpitations, racing pulse, and a pounding sensation in the chest. Those with panic disorder fear future attacks and may become preoccupied with modifying their behavior in an effort to avoid future panic attacks. Panic disorder is often characterized as fear of fear. Panic attacks themselves are not mental disorders. Around 23% of Americans experience isolated panic attacks in their lives without meeting the criteria for panic disorder, indicating that panic attacks are fairly common. Panic disorder is, of course, much less common, afflicting 4.7% of Americans during their lifetime. Many people with panic disorder develop agoraphobia. People with panic disorder often experience a comorbid disorder such as other anxiety disorders or major depressive disorder. Researchers are not entirely sure what causes panic disorder. Studies indicate that the heritability of panic disorder is around 43%, and that's a lot. A region of the brain called the locus ceruleus may play a role in this disorder. Located in the brainstem, the locus ceruleus is the brain's major source of norepinephrine, a neurotransmitter that triggers the body's fight or flight response. Activation of the locus ceruleus is associated with anxiety and fear. Generalized anxiety disorder is a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension. People with generalized anxiety disorder often worry about routine, everyday things, even though their concerns are unjustified. A diagnosis of generalized anxiety disorder requires the diffuse worrying and apprehension characteristic of this disorder is not part of another disorder. That didn't make any sense to me. Let me read it again. A diagnosis of generalized anxiety disorder requires that the diffuse worrying and apprehension characteristic of this disorder is not part of another disorder, occurs more days than not for at least 6 months, and is accompanied by any 3 of the following symptoms: restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. About 5.7% of the U.S. population will develop symptoms of generalized anxiety disorder during their lifetime, and females are 2 times as likely as males to experience the disorder. Generalized anxiety disorder is highly comorbid with mood disorders and other anxiety disorders, and it tends to be chronic. Generalized anxiety disorder appears to increase the risk for heart attacks and strokes, especially in people with pre-existing heart conditions. A summary of available family and twin studies suggests that genetic factors play a modest role in the disorder. Cognitive theories of generalized anxiety disorder suggest that worry represents a mental strategy to avoid more powerful negative emotions, or perhaps stemming from earlier unpleasant or traumatic experiences. One longitudinal study found that childhood maltreatment was strongly related to the development of this disorder during adulthood. Worrying might distract people from remembering painful childhood experiences. Obsessive compulsive and related disorders are a group of overlapping disorders that generally involve intrusive, unpleasant thoughts and repetitive behaviors. Many of us experience unwanted thoughts from time to time and repetitive behaviors, but obsessive compulsive and related disorders elevate the unwanted thoughts and repetitive behaviors to a status so intense that these cognitions and activities disrupt daily life. Included in this category are obsessive compulsive disorder, also known as OCD, body dysmorphic disorder, and hoarding disorder. People with obsessive compulsive disorder experience thoughts and urges that are intrusive and unwanted. These are the obsessions, and or the need to engage in repetitive behaviors or mental acts, and these are the compulsions. Compulsions are the acts, the thoughts are the obsessions. Obsessions are characterized as persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. Common obsessions include concerns about germs and contamination, doubts, order and symmetry, urges that are aggressive or lustful. Usually the person knows that such thoughts and urges are irrational and thus tries to suppress or ignore them, but has an extremely difficult time doing this. My first wife wasn't really obsessive compulsive, but she had this thing about turning off the stove and checking to see if there were intruders in the house. And of course, she couldn't go and do any of this. She wanted me to do it. So I was the one that had to go in. And of course, she didn't believe me the first time I said, yeah, I checked the stove. Yeah, I checked under the bed before she could go in the house. I'd have to go in at least twice, sometimes 3 times, because, I'm a big liar. Well, obviously, that's one of the reasons why she's not currently my wife, because I'm such a liar. Ah, golly, that was fun. Compulsions are repetitive and ritualistic acts that are typically carried out primarily as a means to minimize the distress that obsessions trigger or to reduce the likelihood of a feared event. Compulsions often include such behaviors as repeated and extensive hand washing, cleaning, checking, ordering. They also include such mental acts as counting, praying, or reciting something to oneself. Compulsions characteristic of OCD are not performed out of pleasure, nor are they connected to a realistic way to the source of the distress or feared event. Approximately 2.3% of the United States population will experience OCD in their lifetime, and if left untreated, OCD tends to be a chronic condition, creating lifelong interpersonal and psychological problems. He's being attacked by a bunny rabbit. An individual with body dysmorphic disorder is preoccupied with a perceived flaw in physical appearance that is either non existent or barely noticeable to other people. These perceived physical defects cause people to think they are unattractive, ugly, hideous, or deformed. These preoccupations can focus on any bodily area, but they typically involve the skin, the face, or hair. The preoccupation with imagined physical flaws drives a person to engage in repetitive and ritualistic behavior and mental acts, such as constantly looking in the mirror, trying to hide the offending body part, comparisons with others, and in some extreme cases, cosmetic surgery. An estimated 2.4% of the adults in the United States meet the criteria for body dysmorphic disorder, with slightly higher rates in women than in men. And I'm trying to. Megan Fox is an actress who seems to have body dysmorphic disorder. I think it's her ears that she didn't like. People don't like certain parts of their bodies. Doesn't do you any good. You're going to change. Okay. Oh, okay. This is for people that have body dysmorphic disorder. I don't have a. Yeah, he looks like a Ken doll, doesn't he? And I'm not really sure. She's a Barbie doll, and she's a Barbie doll. He's supposed to be a Ken doll as well. You can see what he looked like before. None of this has anything to do with him doing exercising. He really hates exercising. But yeah, these are all implants, as weird as that is. This is what he looked like once upon a time, and this is what he looks like now. Looks real buff, doesn't he? Well, he's had like 105 cosmetic surgeries. Fun guy. Although hoarding was traditionally considered to be a symptom. Yeah, look at that. I want to look like Ken when I grow up. I want to look like Barbie. Ooh, okay. Although hoarding was and of course the movie just came out. Although hoarding was traditionally considered to be a symptom of OCD, considerable evidence suggests that hoarding represents an entirely different disorder. People with hoarding disorder cannot bear to part with personal possessions, regardless of how valueless or useless these possessions are. As a result, these individuals accumulate excessive amounts of usually worthless items that clutter their living areas. Often the quantity of cluttered items is so excessive that the person is unable to use his kitchen or sleep in his bed. People who suffer from this disorder have great difficulty parting with items because they believe the items might be of some later use, or because they form a sentimental attachment to the items, or they're going to become worth something someday. They watch those television shows where somebody found something in their attic and it turned out to be, a Ming vase that's worth $1.5 million. A diagnosis of hoarding disorder is made only if the hoarding is not caused by another medical condition and if the hoarding is not a symptom of another disorder, such as schizophrenia. Is that it? Yeah. Okay. Yeah, I've seen this a lot. Working in medicine, I've seen this a lot. Hoarding disorder. I have a niece that probably is a hoarder of some ilk, to some extent. She's got this thing about keeping toys. toys that she had when she was a kid. She doesn't open them. If you watched Big Bang Theory, they never opened their toys. It was kind of odd. They never played with them. Um, this is not that uncommon in Montana. Um, or isolated places. People can hoard if they can stay away from other people and nobody can question what they're doing. There was a lady that drove down from Alaska, and when she crossed the border from Canada back into the United States, she was driving a semi. And when she crossed the border, the border guards detected sounds coming from the inside of the semi. So they opened the back of the semi. It turned out that she was transporting 107 collies, um, and other dogs. Most of them were collies, and they determined that she was not properly taking care of them. So they seized them at the border and they took them to the Montana State Fairgrounds in Great Falls. I think it's in Great Falls. Yeah, I think it's in Great Falls. Anyway, they took it to Great Falls, not Helena. Helena's not where the state fair is. And they took them away from them. The judge decided she was a hoarder. That's not the she's not the only one. They Right outside of Great Falls there was a ranch. There's all ranches all over Montana. There was a ranch, and this guy had like 56 dogs and 17 horses, and the only reason they found them and decided that they needed to do something about it was because people started noticing that there were dead animals on his property. Another case, this guy had 200 goats. And for a while he was taking care of them, and then he died. He kept them on this one property. He died, and there was nobody to take care of them, and they all died. I was really ugly, really, really, really ugly. And there was a lady with 200 parakeets. It was just crazy stuff. And I've worked in medicine, and I've seen these people. We've had to go in and take them out of their area to save them from one thing or another. Anyway, yeah, it's kind of interesting. And there's really not a whole lot you can do about it. I mean, it's not like you can condemn the building. You can get them for animal cruelty if their hoarding is of animals. But I mean, other than that, there's not a whole lot you can do if your kitchen looks like this. The results of family and twin studies suggest that OCD has a moderate genetic component. The disorder is 5 times more frequent in the first-degree relatives of people with OCD than in people without the disorder. The concordance rate of OCD among identical twins is around 57%. The concordance rate for fraternal twins is 22%. Studies have implicated about 24 potential genes that may be involved in OCD. These genes regulate the function of 3 neurotransmitters: serotonin, dopamine, and glutamate. A brain region that is believed to play a critical role in OCD is the orbitofrontal cortex, an area of the frontal lobe involved in learning and decision making. And you can see it's this green area right here. In people with OCD, the orbitofrontal cortex becomes especially hyperactive when they are provoked with tasks in which they are asked to look at a photo of a toilet or of pictures hanging crookedly on a wall. The orbitofrontal cortex is part of a series of brain regions that collectively is called the OCD circuit. This circuit consists of several interconnected regions that influence the perceived emotional value of stimuli and the selection of both behavioral and cognitive responses. As with the orbitofrontal cortex, other regions of the OCD circuit show heightened activity during symptom provocation, which suggests that abnormalities in these regions may produce the symptoms of OCD. Extremely stressful or traumatic events, such as combat, natural disasters, and terrorist attacks, place the people who experience them at an increased risk for developing psychological disorders such as post-traumatic stress disorder, also known as PTSD. Throughout much of the 20th century, this disorder was called shell shock and combat neurosis because its symptoms were observed in soldiers who had engaged in wartime combat. By the late 1970s, it had become clear that women who had experienced sexual traumas, such as rape or domestic battery and incest, often experienced the same set of symptoms as did soldiers. The term post-traumatic stress disorder was developed given that these symptoms could happen to anyone who experienced psychological trauma. Symptoms of PTSD include intrusive and distressing memories of the event, flashbacks, states that can last from a few seconds to several days, during which the individual relives the event and behaves as if the event were occurring at the moment, avoidance of a stimuli connected to the event, persistently negative emotional states, for example, fear, anger, guilt, and shame, feelings of detachment from others, irritability, proneness toward outbursts, and an exaggerated startle response, jumpiness. For PTSD to be diagnosed, these symptoms must occur for at least 1 month. And I do have PTSD from my military experience. It has to do with airplane crashes, which luckily or unluckily, I was given the opportunity to collect the cadaver from the airplane crashes. That was my job. I was a laboratory technician, so I collected bodies. Now, one of the things about airplane crashes, a lot of times they burn. They burst into flames. So there's always a smell of smoke. Now, I can handle the smell of smoke. It's the smell of human flesh burning that gives me the whim whams. Now, normally you don't run around smelling people burning each other. It just doesn't happen. But there are some meats that when you cook it, it smells just like human flesh. Luckily, I've only noticed one type of meat, and I won't tell you what it is. I have a friend that he thinks it's something else. And I eat that meat all the time, and it doesn't remind me. But we had different experiences. My job was taking the cadavers out of the, or not. I didn't have to take them out. I just had to accept them, and they put them in the body bag, and I was the one that transported the cadaver to wherever we were holding it. He was more in a combat situation. So his experiences were completely different than mine. We were both in the Air Force, but he felt that it smelled like one thing, and I felt that it smelled like something else. Now the interesting thing is that he grew up with the smell that I find negative, and I grew up with the smell that he found negative, which is really kind of curious that he thinks one thing and I think something totally different. Not important because, like I said, we have had different experiences, and of course that's one of the things I try to stay away from. Yeah, it not pleasant. PTSD is not pleasant, and both of us stay away from fireworks. Yeah, a lot of military people stay away from fireworks. It's not uncommon. Roughly 7% of adults in the United States, including 9.7% of women and 3.6% of men, experience PTSD in their lifetime, with higher rates among people exposed to mass trauma and people whose jobs involve duty-related trauma exposure, like police officers, firefighters, and emergency medical personnel. Nearly 21% of residents of areas affected by Hurricane Katrina suffered from PTSD 1 year following the hurricane, and 12.6% of Manhattan residents were observed as having PTSD 2 to 3 years after the 9/11 terrorist attacks. And I can tell you that my dad had PTSD from World War II, and my brother has PTSD from Vietnam. Really kind of curious. He, my my brother built machine gun nests around our property. after he came back, which was kind of interesting because he didn't have a machine gun. But just in case, you never know. Several factors strongly predict the development of PTSD. Trauma experience, greater trauma severity, lack of immediate social support, and more subsequent life stress. Traumatic events that involve harm by others, such as combat, rape, and sexual molestation, carry greater risk than do other traumas like natural disasters. Women are more likely to have been traumatized because of sexual trauma, childhood neglect, and childhood physical abuse. Men are more likely to have been traumatized by natural disaster, life-threatening accident, and physical violence, either witnessed or directed at them. Adolescent boys are more likely to experience accidents, physical assault, and witness death or injury. Adolescent girls are more likely to experience rape, sexual assault, intimate partner violence, or unexpected death or injury of a loved one. Assaultive violence and witnessing trauma to others is more prevalent among non-whites when compared to whites. African American males are more likely to be exposed to and victims of violence than males of other races. A 2012 study found that 27% of correction officers reported experiencing symptoms of PTSD in the past 30 days. Rates were higher for males, 31%, than for females, 22%. A study conducted by Jagers et al. In 2019 found that 53.4% of jail correctional officers screened positively for PTSD. PTSD is more prevalent in prison populations than in the general public, with prevalence estimates of 6% in male prisoners and 21% in female prisoners. Factors that increase the risk of PTSD include female gender, low socioeconomic status, low intelligence, personal history of mental disorders, history of childhood adversity, abuse or other trauma during childhood, and family history of mental disorders. Personality characteristics such as neuroticism and somatization, the tendency to experience physical symptoms when one encounters stress, have been shown to elevate the risk of PTSD. People who experience childhood adversity and or traumatic experiences during adulthood are at significantly higher risk of developing PTSD if they possess one or two short versions of a gene that regulates the neurotransmitter serotonin. Research has shown that social support following a traumatic event can reduce the likelihood of PTSD. Social support is often defined as the comfort, advice, and assistance received from relatives, friends, and neighbors. Social support can help individuals cope during difficult times by allowing them to discuss feelings and experiences and providing a sense of being loved and appreciated. Mood disorders are characterized by severe disturbances in mood and emotions, most often depression, but also mania and elation. People with mood disorders also experience mood fluctuations, but their fluctuations are extreme, distort their outlook of life, and impair their ability to function. Depressive disorders are a group of disorders in which depression is the main feature. Depression is a vague term that, in everyday language, refers to an intense and persistent sadness. Depression is a heterogeneous mood state. It consists of a broad spectrum of symptoms that range in severity. Depressed people feel sad, discouraged, and hopeless. These individuals lose interest in activities once enjoyed, often experience a decrease in drive, such as hunger and sex, and frequently doubt personal worth. Bipolar and related disorders are a group of disorders in which mania is the defining feature. Mania is a state of extreme elation and agitation. When people experience mania, they may become extremely talkative, behave recklessly, or attempt to take on many tasks simultaneously. The most recognized of these disorders is bipolar disorder. According to the DSM-5, the defining symptoms of major depressive disorder include depressed mood most of the day, nearly every day, feeling sad, empty, hopeless, or appearing tearful to others, and loss of interest and pleasure in usual activities. In addition to feeling overwhelmingly sad most of each day, people with depression will no longer show interest or enjoyment in activities that previously were gratifying. To receive a diagnosis of major depressive disorder, one must experience a total of 5 symptoms for at least a 2-week period. These symptoms must cause significant distress or impair normal functioning, and they must not be caused by substances or a medical condition. At least one of the 2 symptoms mentioned above must be present, plus any combination of the following symptoms: significant weight loss when not dieting, or weight gain and or significant decrease or increase in appetite, difficulty falling asleep or sleeping too much, psychomotor agitation, the person is noticeably fidgety and jittery, demonstrated by behaviors like inability to sit, pacing, hand-wringing, pulling or rubbing of the skin, clothing or other objects, or psychomotor retardation. The person talks and moves slowly, for example, talking softly, very little, or in a monotone. Fatigue, that's not what I'm doing right now. Fatigue or loss of energy, feeling of worthlessness or guilt, difficulty concentrating or indecisiveness. Suicidal ideation, thoughts of death, not just fear of dying, thinking about planning suicide, or making an actual suicide attempt. Major depressive disorder is considered episodic. Its symptoms are typically present at their full magnitude for a certain period of time and then gradually abate. Approximately 50 to 60% of people who experience an episode of major depressive disorder will have a second episode at some point in the future. Those who have had 2 episodes have a 70% chance of having a third episode, and those who have had 3 episodes have a 90% chance of having a fourth episode. Although the episodes can last for months, a majority of people diagnosed with this condition, around 70%, recover within a year. A substantial number do not recover. Around 12% show serious signs of impairment associated with major depressive disorder after 5 years. Many who do recover will still show minor symptoms that fluctuate in their severity, and there's a reason for this. And the reason is the human brain can't tolerate that type of thought pattern for an extended length of time. It just can't do it, and that's one of the reasons why you get over these things. Why things are episodic. Why they fluctuate from one moment to the, or not one moment, but from one time period to another. You just can't handle that. The brain otherwise would shut down. So it tries to cure itself. It does things like the neurons increase their receptors, the number of receptors they have. So maybe they can find some serotonin in there to make them feel better. These are the things that the brain will do in order to keep from being in this kind of a state for an extended length of time. And that's one of the reasons why these things are so episodic. Major depressive disorder is a serious and incapacitating condition that can have a devastating effect on the quality of one's life. The person suffering from this disorder lives a profoundly miserable existence that often results in unavailability for work or education, abandonment of promising careers, and lost wages. Occasionally, the condition requires hospitalization. The majority of those with major depressive disorder report having faced some kind of discrimination, and many report that having received such treatment has stopped them from initiating close relationships, applying for jobs for which they are qualified, and applying for education or training. Major depressive disorder also takes a toll on health. Depression is a risk factor for the development of heart disease in healthy patients. Major depressive disorder is often referred to as the common cold of psychiatric disorders. Around 6.6% of U.S. population experiences major depressive disorder each year. 16.9% will experience the disorder during their lifetime. It is more common among women than among men, affecting approximately 20% of women and 13% of men at some point in their life. The greater risk among women is not accounted for by a tendency to report symptoms or to seek help more readily, suggesting that gender differences in the rates of major depressive disorder may reflect biological and gender-related environmental experiences. And one of the things that they noted was that people that are Amish, uh, males and female Amish people have exactly the same, the males and females have the same rates of depression. Whereas in, well, anyway, what is this? Lifetime rates of major depressive disorder tend to be highest in North and South America, Europe, and Australia. They are considerably lower in Asian countries. The rates of major depressive disorder are higher among younger age cohorts than among older cohorts, perhaps because people in younger age cohorts are more willing to admit depression. And that's Amy Winehouse, and I'm not exactly sure where this picture came from. A number of risk factors are associated with major depressive disorder. Unemployment, including homemakers, earning less than $20,000 per year, living in an urban area, being separated, divorced, or widowed. Comorbid disorders include anxiety disorders and substance abuse disorders. And of course, we're watching women smoke. One of the things we know about tobacco is that it raises your dopamine level. So if you are depressed, then it's going to make you feel better because it's going to raise your dope. You're going to get a dopamine spike every time you suck in that tobacco smoke. The DSM-5 lists several different subtypes of depression. These subtypes specifiers are not specific disorders. Rather, they are labels used to indicate specific patterns of symptoms or to specify certain periods of time in which the symptoms may be present. One subtype, seasonal pattern, applies to situations in which a person experiences the symptoms of major depressive disorder only during a particular time of the year, and these are known as the winter blues. And that may have something to do with the fact that there is less sunlight in the wintertime. So people that who live closer to the Canadian border have more seasonal affective disorder, also known as SAD, seasonal affective disorder, than people who live in Arizona, for example, or New Mexico, because they have less sunlight. Peripartum onset, commonly referred to as postpartum depression, applies to women who experience major depression during pregnancy or in the 4 weeks following the birth of their child. These women often feel very anxious and may even have panic attacks. They may feel guilty, agitated, and be weepy. They may not want to hold or care for their newborn, even in cases in which the pregnancy was desired and intended. In extreme cases, a mother may have feelings of wanting to harm the child or herself. Most women with peripartum onset depression do not physically harm their children, but most do have difficulty being adequate caregivers. A surprisingly high number of women experience symptoms of peripartum onset depression. In one study, 14% screened positive for peripartum onset depression, and that nearly 20% reported having thoughts of wanting to harm themselves. This is really kind of interesting because I just read an article that said 80% of women, let's see, what did it say? This is the most common problem that pregnancy has, that women who are pregnant have, is depression. Not just peripartum onset depression, but depression during their pregnancy as well. It was really kind of interesting. And they said that doctors need to focus more on this because, you know, the old saw was that all women are good mothers and they all want their babies. And of course, that's just not entirely true, especially with individuals suffering from peripartum onset depression. People with persistent depressive disorder, previously known as dysthymia, experience depressed moods most of the day, nearly every day for at least 2 years, as well as at least 2 of the other symptoms of major depressive disorder. People with persistent depressive disorder are chronically sad and melancholy, but do not meet all the criteria for major depression. Episodes of full-blown major depressive disorder can occur during persistent depressive disorder. A person with bipolar disorder, commonly known as manic depression, often experiences mood states that vacillate between depression and mania. That is, the person's mood is said to alternate from one emotional extreme to the other, in contrast to unipolar, which indicates a persistently sad mood. To be diagnosed with bipolar disorder, a person must have experienced a manic episode at least once in his life. Although major depressive episodes are common in bipolar disorder, they are not required for a diagnosis. According to the DSM-5, a manic episode is characterized as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally persistently increased activity or energy lasting at least 1 week. That lasts most of the time each day. During a manic episode, some experience a mood that is almost euphoric and become excessively talkative, sometimes spontaneously starting conversations with strangers. Others become excessively irritable and complain or make hostile comments. The person may talk loudly and rapidly, exhibiting flight of ideas, abruptly switching from one topic to another. These individuals are easily distracted, which can make a conversation very difficult. They may exhibit grandiosity, in which they experience inflated but unjustified self-esteem and self-confidence. They may take on several tasks at the same time, for example, several time-consuming projects at work, and yet show little, if any, need for sleep. Some may go for days without sleep. Patients may also recklessly engage in pleasurable activities that could have harmful consequences, including spending sprees, reckless driving, making foolish investments, excessive gambling, or engaging in sexual encounters with strangers. During a manic episode, individuals usually feel as though they are not ill and do not need treatment. However, the reckless behaviors that often accompany these episodes, which can be antisocial, illegal, or physically threatening to others, may require involuntary hospitalization. Some patients with bipolar disorder will experience a rapid cycling subtype, which is characterized by at least 4 manic episodes, or some combination of at least 4 manic and major depressive episodes within 1 year. In the United States, 1 out of every 167 people meets the criteria for bipolar disorder each year, and 1 out of 100 meet the criteria within their lifetime. The rates are higher in men than in women, and about half of those with this disorder report onset before the age of 25. Around 90% of those with bipolar disorder have a comorbid disorder, most often an anxiety disorder or a substance abuse problem. Close to half the people suffering from bipolar disorder do not receive treatment. Suicide rates are extremely high among those with bipolar disorder. Around 36% of individuals with this disorder attempt suicide at least once in their lifetime, and between 15% and 19% complete suicide. Mood disorders have been shown to have a strong genetic and biological basis. Relatives of those with major depressive disorder have double the risk of developing major depressive disorder, whereas relatives of patients with bipolar disorder have over 9 times the risk. The rate of concordance for major depressive disorder is higher among identical twins than fraternal twins, 50% versus 38%, respectively, as is that of bipolar disorder, 67% versus 16%, respectively, suggesting that genetic factors play a stronger role in bipolar disorder than in major depressive disorder. People with mood disorders often have imbalances in certain neurotransmitters, particularly norepinephrine and serotonin. These neurotransmitters are important regulators of the bodily functions that are disrupted in mood disorders, including appetite, your sex drive, sleep, arousal, and mood. Medications that are used to treat major depressive disorder typically boost serotonin and norepinephrine activity, whereas lithium, used in the treatment of bipolar disorder, blocks norepinephrine activity at the synapses. Depression is linked to abnormal activity in several regions of the brain, including those important in assessing the emotional significance of stimuli and experiencing emotions, that's the amygdala, and in regulating and controlling emotions, like the prefrontal cortex or the PFC. Let's not call it the PFC, let's call it the prefrontal cortex. Depressed individuals show elevated amygdala activity, especially when presented with negative emotional stimuli. Heightened amygdala activation to negative emotional stimuli among depressed persons occurs even when stimuli are presented outside of the conscious awareness, and it persists even after the negative emotional stimuli are no longer present. Depressed individuals exhibit less activation in the prefrontal area, particularly on the left side. Because the prefrontal cortex can dampen amygdala activation, thereby enabling one to suppress negative emotions, decreased activation in certain regions of the prefrontal cortex may inhibit its ability to override negative emotions that might then lead to more negative mood states. These findings suggest that depressed persons are more prone to react to emotionally negative stimuli, yet have greater difficulty controlling these reactions. Researchers have noted that depressed individuals have abnormal levels of cortisol. When cortisol is released, the body initiates a fight or flight response in reaction to a threat or danger. Many people with depression show elevated cortisol levels, especially those reporting a history of early life trauma. High levels of cortisol are a risk factor for future depression, and cortisol activates activity in the amygdala while deactivating activity in the prefrontal cortex. Both brain disturbances are connected to depression. High cortisol levels may have a causal effect on depression, as well as on its brain function abnormalities. Because stress results in increased cortisol release, it is possible that stress may precipitate depression. For some people, extreme emotional pain they experience becomes unendurable. Overwhelmed by hopelessness, devastated by incapacitating feelings of worthlessness, and burdened with the inability to adequately cope with such feelings, they may consider suicide to be a reasonable way out. Suicide is defined as death caused by self-directed injurious behavior with any intent to die as a result of the behavior. Suffering from a mental disorder, especially a mood disorder, poses the greater risk for suicide. Around 90% of those who complete suicides have a diagnosis of at least one mental disorder, with mood disorders being the most frequent. The association between major depressive disorder and suicide is so strong that one of the criteria for the disorder is thoughts of suicide. Investigations into U.S. suicide rates. Suicide was the 10th leading cause of death for all ages in 2010. There were 38,364 suicides in 2010 in the United States, an average of 105 each day. Suicide among males is 4 times higher than among females and accounts for 79% of all suicides. Firearms are the most commonly used method of suicide for males, whereas poisoning is the most commonly used method for females. From 1991 to 2003, suicide rates were consistently higher among those 65 years and older. Since 2001, suicide rates among those ages 25 to 64 has risen consistently, and since 2006, suicide rates have been greater for those ages 65 and older, and this is according to the CDC in 2013. This increase in suicide rates among middle-aged Americans has prompted concern in some quarters that baby boomers, individuals born between 1946 and 1964, who face economic worry and easy access to prescription medication, may be particularly vulnerable to suicide. The highest rates of suicide within the United States are among American Indian, Alaska Natives, and non-Hispanic whites.
Suicide rates vary across the United States, with the highest rates consistently found in the mountain states of the West: Alaska, Montana, Nevada, Wyoming, Colorado, and Idaho. Suicidal risk is especially high among people with substance abuse problems. Individuals with alcohol dependence are at a 10 times greater risk for suicide than the general population. The risk of suicidal behavior is especially high among those who have made a prior suicide attempt. Among those who attempt suicide, 16% make another attempt within a year, and over 21% make another attempt within 4 years. Suicidal individuals may be at risk for terminating their life if they have a lethal means in which to act, such as a firearm in the home or a knife on a ledge. Wait a minute, he's dead, she's dead, and he's jumping off a cliff. Withdrawal from social relationships, feeling as though one is burdened to others, and engaging in reckless and risk-taking behaviors may be precursors to suicidal behavior. A sense of entrapment, of feeling unable to escape one's miserable feelings or external circumstances, such as an abusive relationship with no perceived way out, predicts suicidal behavior. Suicides can have a contagious effect on people. A review of 42 studies included that media coverage of celebrity suicides is more than 14 times more likely to trigger copycat suicides than is coverage of non-celebrity suicides. This is Bourdain. He was a CNN reporter and chef, and he committed suicide about a year ago, I think. This is Kurt Cobain. That's Robin Williams, and that's Marilyn Monroe. And I don't recognize these two people, so I'm assuming they committed suicide too. Schizophrenia is a devastating psychological disorder that is characterized by major disturbances in thought, perception, emotion, and behavior. About 1% of the population experiences schizophrenia in their lifetime, and usually the disorder is first diagnosed during early adulthood, early to mid-20s. And I have a niece that has schizophrenia, and her daughter has schizophrenia, I think. Maybe, who knows? Most people with schizophrenia experience significant difficulties in many day-to-day activities, such as holding a job, paying bills, caring for oneself, grooming and hygiene, and maintaining relationships with others. Frequent hospitalizations are more often the rule rather than the exception with schizophrenia. Even when they receive the best treatments available, many with schizophrenia will continue to experience serious social and occupational impairment throughout their lives. Schizophrenia is considered a psychotic disorder, or one in which the person's thoughts, perceptions, and behaviors are impaired to the point where they are not able to function normally in life. In informal terms, one who suffers from a psychotic disorder, that is, has a psychosis, is disconnected with the world in which most of us live. The main symptoms of schizophrenia include hallucinations, delusions, disorganized thinking, disorganized or abnormal motor behavior, and negative symptoms. And hallucination is a perceptual experience that occurs in the absence of external stimuli. Auditory hallucinations, hearing voices, occur in roughly 2/3 of patients with schizophrenia and are by far the most common form of hallucination. The voices may be familiar or unfamiliar. They may have a conversation or argue, or the voices may provide a running commentary on the person's behavior. Less common are visual hallucinations, seeing things that are not there, and olfactory hallucinations, smelling odors that are not actually present. Delusions are beliefs that are contrary to reality and are firmly held even in the face of contradictory evidence. Many of us hold beliefs that some would consider odd, but a delusion is easily identified because it is clearly absurd. A person with schizophrenia may believe that his mother is plotting with the FBI to poison his coffee, or that his neighbor is an enemy spy who wants to kill him. These kinds of delusions are known as paranoid delusions, which involve the false belief that other people or agencies are plotting to harm the person. People with schizophrenia also may hold grandiose delusions, beliefs that one holds special power, unique knowledge, or is extremely important. For example, the person who claims to be Jesus Christ, or who claims to have knowledge going back 5,000 years, or who claims to be a great philosopher is experiencing grandiose delusions. Other delusions include the belief that one's thoughts are being removed, thought withdrawal, or thoughts have been placed inside one's head, thought insertion. Another type of delusion is somatic delusion, which is the belief that something highly abnormal is happening to one's body. For example, that one's kidneys are being eaten by cockroaches. Disorganized thinking refers to disjointed and incoherent thought processes, usually detected by what a person says. The person might ramble, exhibit loose associations, jump from topic to topic, or talk in a way that is so disorganized and incomprehensible that it seems as though the person is randomly combining words. Disorganized thinking is also exhibited by blatantly illogical remarks and by tangentially responding to other statements or questions by remarks that are either barely related or unrelated to what was said or asked. Disorganized or abnormal motor behavior refers to unusual behaviors and movements, becoming unusually active, exhibiting silly childlike behaviors, giggling and self-absorbed smiling, engaging in repeated and purposeless movements, or displaying odd facial expressions and gestures. In some cases, a person will exhibit catatonic behaviors, which show decreased reactivity to the environment, such as posturing, in which the person maintains a rigid and bizarre posture for long periods of time, or catatonic stupor, a complete lack of movement and verbal behavior. Negative symptoms are those that reflect noticeable decreases and absences in certain behaviors, emotions, or drives. A person who exhibits diminished emotional expression shows no emotion in his facial expressions, speech, or movements, even when such expressions are normal or expected. Avolition is characterized by a lack of motivation to engage in self-initiated and meaningful activity, including the most basic of tasks, such as bathing and grooming. Alogia refers to reduced speech output. Patients do not say much. Asociality or social withdrawal, and a lack of interest in engaging social interactions with others. Anhedonia refers to an inability to experience pleasure. One who exhibits anhedonia expresses little interest in what most people consider to be pleasurable activities, such as hobbies, recreation, or sexual activity. There is considerable evidence suggesting that schizophrenia has a genetic basis. The risk of developing schizophrenia is nearly 6 times greater if one has a parent with schizophrenia than if one does not. One risk of developing schizophrenia increases as genetic relatedness to family members diagnosed with schizophrenia increases. This is a family, and what is it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. This is a family of 12, and 8 of these kids had schizophrenia. Which ones had schizophrenia? You can tell. The ones that aren't looking at the camera, the ones that aren't smiling. And there's 8 of them. Well, I can't tell with the baby. Okay. He's one, he's one. He's one, he's one, he's one. Have I hit the magic number yet? He's one. Is that 8? We don't know about the baby. We've got 1, 2, 3, 4, 5, 6, 7. I think that's it. And then maybe the baby. Anyway, Interesting picture. Oh, the father had schizophrenia. That's why he's not in the picture. The dopamine hypothesis of schizophrenia proposes that an overabundance of dopamine or too many dopamine receptors are responsible for the onset and maintenance of schizophrenia. More recent research has suggested that an overabundance of dopamine in the limbic system may be responsible for some symptoms, such as hallucinations and delusions, whereas low levels of dopamine in the prefrontal cortex might be responsible primarily for the negative symptoms: avolition, alogia, asociality, and anhedonia. In recent years, serotonin has received attention, and newer antipsychotic medications used to treat the disorder work by blocking serotonin receptors. Brain imaging studies reveal that people with schizophrenia have enlarged ventricles. That's the open areas in the brain. And these are the ventricles. And this is what they're supposed to look like. And this is what they look like in the schizophrenic individual's brain. The cavities within the brain that contain cerebrospinal fluid. This finding is important because larger than normal ventricles suggest that various brain regions are reduced in size, thus implying that schizophrenia is associated with a loss of brain tissue. Many people with schizophrenia display a reduction in gray matter, cells bodies of the neurons, in the frontal lobes, and many show less frontal lobe activity when performing cognitive tasks. The frontal lobes are important in a variety of complex cognitive functions such as planning and executive behavior, attention, speech, movement, and problem solving. Abnormalities in this region provide merit in explaining why people with schizophrenia experience deficits in these areas. High rates of obstetric complications in births of children who later develop schizophrenia have been reported. People are at an increased risk for developing schizophrenia if their mother was exposed to influenza during the first trimester of pregnancy. That means they would be born in the spring. Research has also suggested that a mother's emotional stress during pregnancy may increase the risk of schizophrenia in offspring. Research reports that the risk of schizophrenia is elevated substantially in offspring whose mothers experience the death of a relative during the first trimester of pregnancy. The available evidence seems to indicate that marijuana use plays a causal role in the development of schizophrenia, although it is important to point out that marijuana use is not an essential or sufficient risk factor, as not all people with schizophrenia have used marijuana, and the majority of marijuana users do not develop schizophrenia. One plausible interpretation of the data is that early marijuana use may disrupt normal brain development during important early maturation periods in adolescence. A new approach involves identifying people who show minor symptoms of psychosis, such as unusual thought content, paranoia, odd communication, delusions, problems at school or work, and a decline in social functioning. And these are known as prodromal symptoms, and following these individuals over time to determine which of them develop a psychotic disorder and which factors best predict such a disorder. A number of factors have been identified that predict a greater likelihood that prodromal individuals will develop a psychotic disorder: genetic risk, a family history of psychosis, recent deterioration in functioning, high levels of unusual thought content, high levels of suspicion or paranoia, poor social functioning, and a history of substance abuse. Dissociative disorders are characterized by an individual becoming split off or dissociated from their core sense of self. Memory and identity become disturbed. These disturbances have psychological rather than physical causes. Dissociative disorders listed in DSM-5 include dissociative amnesia, depersonalization derealization disorder, and dissociative identity disorder. Amnesia refers to the partial or total forgetting of some experience or event. An individual with dissociative amnesia is unable to recall important personal information, usually following an extremely stressful or traumatic experience such as combat, natural disasters, or being the victim of violence. The memory impairments are not caused by ordinary forgetting. Some individuals with dissociative amnesia will also experience dissociative fugue, from the word to flee in French, whereby they suddenly wander away from their home, experience confusion about their identity, and sometimes even adopt a new identity. Most fugue episodes last only a few hours or days, but some can last longer. There was a case in Wichita Falls, Texas, when we were there. Really fascinating. They found his truck in the creek with the doors open, and the radio was still on, and the car was still running. And they thought that he had committed suicide, that somebody had stolen him, and so they looked for him for weeks. It was this rich guy's kid. He owned this huge ranch. It was a really nice pickup truck. The whole thing. And so it was like 5 years later, they found him in Dallas. This was in Wichita Falls, and Wichita Falls, I don't know, about 200 miles from Dallas. They found him in Dallas, and he was preaching. He was a preacher, and he never went to church. Never went to church as a kid, but they found him preaching in a Methodist church, in a gay church, and that was the weird part. The family was very negative about gay people. Now he wasn't gay. That was the interesting thing. He wasn't gay, and he was married as the to a new person. He had also been married to a person in Wichita Falls, and he had a couple kids. And now he was married to somebody else with a different name, and somebody had gone to the service, and they had recognized him from Wichita Falls. The weirdest thing in the world. Anyway, and the question was, what did they do? And who is he married to? He's married to both women, actually, and it hadn't been long enough to declare him dead. He needed to be gone for 7 years before they could declare him dead, because they had no corpus delicti. Anyway, there you go. That was really kind of strange. Of course, he was from a very wealthy family, so that probably hid everything after they discovered what was going on. Depersonalization derealization disorder is characterized by recurring episodes of depersonalization, derealization, or both. Depersonalization is defined as feelings of unreality or detachment from or unfamiliarity with one's whole self or from aspects of the self. Individuals who experience depersonalization might believe their thoughts and feelings are not their own. They may feel robotic, as though they lack control over their movements and speech. They may experience a distorted sense of time, and in extreme cases, they may sense an out-of-body experience in which they see themselves from the vantage point of another person. Derealization is conceptualized as a sense of unreality or detachment from or unfamiliarity with the world, individuals, inanimate objects, or all surroundings. A person who experiences derealization might feel as though they are in a fog or a dream, or that the surrounding world is somehow artificial and unreal. Individuals with depersonalization derealization disorder often have difficulty describing their symptoms and may think they're going crazy. By far the most well-known dissociative disorder is dissociative identity disorder, formerly called multiple personality disorder. People with dissociative identity disorder exhibit two or more separate personalities or identities, each well-defined and distinct from one another. They also experience memory gaps for the time during which another identity is in charge. One might find unfamiliar items in her shopping bags or among her possessions, and in some cases may report hearing voices such as a child's voice or a sound of somebody crying. Despite its controversial nature, DID is clearly a legitimate and serious disorder, where some may suffer their entire lives with it. People with this disorder tend to report a history of childhood trauma. Research suggests that people with DID, dissociative identity disorder, were physically and or sexually abused as children. There is strong evidence that traumatic experiences can cause people to experience states of dissociation, suggesting that dissociative states, including the adoption of multiple personalities, may serve as a psychologically important coping mechanism for threat and danger. There are a group of conditions that are diagnosed early in childhood, often before the time a child enters school. These conditions are listed in the DSM-5 as neurodevelopmental disorders, and they involve developmental problems in personal, social, academic, and intellectual functioning. The symptoms of attention deficit hyperactivity disorder were first described by Hans Hofmann in the 1920s. While taking care of his son while his wife was in the hospital giving birth to a second child, Hoffman noticed that the boy had trouble concentrating on his homework, had a short attention span, and had to repeatedly go over easy homework to learn the material. Later, it was discovered that many hyperactive children, those who are fidgety, restless, socially disruptive, and have trouble with impulse control, also display short attention spans, problems with concentration, and distractibility. By the 1970s, it had become clear that many children who display attention problems often also exhibit signs of hyperactivity. In recognition of such findings, the DSM-3, published in 1980, included a new disorder, attention deficit hyperactivity disorder, with and without hyperactivity, now known as attention deficit hyperactivity disorder, or ADHD. Now, this is really kind of interesting because when I first started studying psychology, they used to call it hyperkinesis or hypermovement. That's what they called ADHD. A child with ADHD shows a constant pattern of inattention and or hyperactive and impulsive behaviors that interferes with normal functioning. Some of the signs of inattention include great difficulty with and avoidance of tasks that require sustained attention, such as conversations or reading, failure to follow instructions, often resulting in failure to complete schoolwork and other duties, disorganization, difficulty keeping things in order, poor time management, sloppy and messy work, lack of attention to detail, becoming easily distracted, and forgetfulness. Hyperactivity is characterized by excessive movement and includes fidgeting or squirming, leaving one's seat in situations when remaining seated is expected, having trouble sitting still, for example, in a restaurant, running about and climbing on things, blurting out responses before another person's question or statement has been completed, difficulty waiting one's turn for something, and interrupting and intruding on others. Frequently, the hyperactive child comes across as noisy and boisterous. The child's behavior is hasty, impulsive, and seems to occur without much forethought. These characteristics may explain why adolescents and young adults diagnosed with ADHD receive more traffic tickets and have more automobile accidents than do others. ADHD occurs in about 5% of children. On the average, boys are 3 times more likely to have ADHD than are girls. Children with ADHD face severe academic and social challenges. Compared to their non-ADHD counterparts, children with ADHD have lower grades, standardized test scores, and higher rates of expulsion, grade retention, and dropping out. They also are less well-liked and more often rejected by their peers. ADHD was thought to fade away by adolescence. Longitudinal studies have suggested that ADHD is a chronic problem, one that can persist into adolescence and adulthood. A recent study found that 29.3% of adults who had been diagnosed with ADHD decades earlier still showed symptoms. Those who were diagnosed with ADHD as children had worse educational attainment, more likely to have dropped out of high school, and less likely to have earned a bachelor's degree, had lower socioeconomic status, held less prestigious occupational positions, were more likely to be unemployed, made considerably less in salary, scored worse on a measure of occupational functioning, indicating, for example, lower job satisfaction, poorer work relationships, and more firings. scored worse on a measure of social functioning, indicating, for example, fewer friendships and less involvement in social activities, were more likely to be divorced, or more likely to have non-alcohol related substance abuse problems. Genetics plays a significant role in the development of ADHD. The median rate of concordance for identical twins was 0.66, whereas the median concordance rate for fraternal twins was 0.20. Another review of studies included the heritability of inattention and hyperactivity were 71% and 73%, respectively. The specific genes involved in ADHD are thought to include at least two that are important in the regulation of the neurotransmitter dopamine, suggesting that dopamine may be important in ADHD. Medications used in the treatment of ADHD, such as methylphenidate, Ritalin, and amphetamine with dextroamphetamine, Adderall, have stimulant qualities and elevate dopamine activity. People with ADHD show less dopamine activity in key regions of the brain, especially those associated with motivation and reward, which provides support to the theory that dopamine deficits may be a vital factor in the development of this disorder. Studies have shown that children with ADHD exhibit abnormalities in their frontal lobes, an area in which dopamine is in abundance. Those with ADHD appear to have smaller frontal lobe volume, and they show less frontal lobe activation when performing mental tasks. One of the functions of the frontal lobe is to inhibit our behavior. Thus, abnormalities in this region may go a long way toward explaining the hyperactivity and uncontrolled behavior of ADHD. In the 1970s, much of the public believed that hyperactivity was caused by sugar and food additives, such as artificial coloring and flavoring. However, studies concluded that sugar consumption has no effect at all on the behavioral and cognitive performance of children. Studies have shown a significant relationship between exposure to nicotine in cigarette smoke during the prenatal period and ADHD. Maternal smoking during pregnancy is associated with the development of more severe symptoms of the disorder. Is ADHD caused by poor parenting? Not likely. Autism spectrum disorder is probably the most misunderstood and puzzling of the neurodevelopmental disorders. Children with this disorder show signs of significant disturbances in three main areas. A, deficits in social interaction, B, deficits in communication, and C, repetitive patterns of behavior or interests. These disturbances appear early in life and cause serious impairments in functioning. The child with autism spectrum disorder might exhibit deficits in social interaction by not initiating conversations with other children or turning away when spoken to. Typically, these children do not make eye contact with others and seem to prefer playing alone. These individuals live in a personal and isolated social world others are not privy to or able to penetrate. Communication deficits can range from a complete lack of speech to one-word responses to echoed speech, for example, parroting what another person says, either immediately or several hours or even days later, to difficulty maintaining a conversation because of an inability to reciprocate others' comments. These deficits can also include problems in using and understanding nonverbal cues that facilitate normal communication. Repetitive patterns of behavior or interest can be exhibited a number of ways. The child might engage in stereotyped repetitive movements, rocking, headbanging, or repeatedly dropping an object and then picking it up. Rocking is the most common. Or they might show great distress at small changes in routine or the environment. The person with autism spectrum disorder might show highly restricted and fixated interests that appear to be abnormal in their intensity. Autism spectrum disorder is not the same thing as intellectual disability, although these two conditions are often comorbid. The DSM-5 specifies that the symptoms of autism spectrum disorder are not caused or explained by intellectual disability. Current estimates from CDC indicates that 1 in 59 children in the United States has autism spectrum disorder. The disorder is 4 times more common among boys, 1 in 38, than in girls, 1 in 152. Rates of autistic spectrum disorder have increased dramatically since the 1980s. It is possible that the rise in prevalence is the result of a broadening of the diagnosis, increased efforts to identify cases in the community, and greater awareness and acceptance of the diagnosis. Autism appears to be strongly influenced by genetics, as identical twins show concordance rates of 60 to 90%, whereas concordance rates for fraternal twins and siblings are 5 to 10%. Many different genes and gene mutations have been implicated in autism. Among the genes involved are those important to the formation of synaptic circuits that facilitate communication between different areas of the brain. A number of environmental factors are also thought to be associated with increased risk for autism spectrum disorder because they contribute to new mutations. These factors include exposure to pollutants such as plant emissions and mercury, urban versus rural residents, and vitamin D deficiency. The term personality refers loosely to one's stable, consistent, and distinctive way of thinking about, feeling, acting, and relating to the world. People with personality disorders exhibit a personality style that differs markedly from the expectations of their culture, is pervasive and inflexible, begins in adolescence or early adulthood, and causes distress or impairment. Individuals with these disorders exhibit enduring personality styles that are extremely troubling and often create problems for them and those with whom they come in contact. Their maladaptive personality styles frequently bring them into conflict with others, disrupt their ability to develop and maintain social relationships, and prevent them from accomplishing realistic life goals. The DSM-5 recognizes 10 personality disorders organized into 3 different clusters. Cluster A disorders include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. People with these disorders display a personality style that is odd or eccentric. Cluster B disorders include antisocial personality disorder, histrionic personality disorder, narcissistic personality disorder, and borderline personality disorder. People with these disorders usually are impulsive, overly dramatic, highly emotional, and erratic. Cluster C disorders include avoidant personality disorder, dependent personality disorder, and obsessive-compulsive personality disorder, which is not the same thing as obsessive-compulsive disorder. People with these disorders often appear to be nervous and fearful. Slightly over 9% of the U.S. population suffers from a personality disorder, with avoidant and schizoid personality disorders the most frequent. 2 of these personality disorders, borderline personality disorder and antisocial personality disorder, are regarded as by many as especially problematic. Borderline personality disorder is characterized chiefly by instability in the interpersonal relationships, self-image, and mood, as well as marked impulsivity. People with borderline personality disorder cannot tolerate the thought of being alone and will make frantic efforts, including making suicidal gestures and engaging in self-mutilation, to avoid abandonment or separation, whether real or imagined. Their relationships are intense and unstable. These individuals have an unstable view of self and might suddenly display a shift in personal attitudes, interests, career plans, and the choice of friends. People with borderline personality disorder may be highly impulsive and may engage in reckless and self-destructive behaviors such as excessive gambling, spending money irresponsibly, substance abuse, engaging in unsafe sex, and reckless driving. They sometimes show intense and inappropriate anger that they have difficulty controlling, and they can be moody, sarcastic, bitter, and verbally abusive. The prevalence of borderline personality disorder in the United States population is estimated to be around 1.4%, but the rates are higher among those who use mental health services. Approximately 10% of mental health outpatients and 20% of psychiatric inpatients meet the criteria for the diagnosis of borderline personality disorder. Additionally, borderline personality disorder is comorbid with anxiety, mood, and substance use disorders. Genetic factors appear to be important in the development of borderline personality disorder. Core personality traits that characterize this disorder, such as impulsivity and emotional instability, show a high degree of heritability. The rates of borderline personality disorder among relatives of people with this disorder have been found to be as high as 24.9%. Individuals with borderline personality disorder report experiencing childhood physical, sexual, and/or emotional abuse at the rates far greater than those observed in the general population, and indicating that environmental factors are also crucial. According to the DSM-5, the individual with antisocial personality disorder shows no regard at all for other people's rights or feelings. This lack of regard is exhibited a number of ways and can include repeatedly performing illegal acts, lying to or conning others, impulsivity and recklessness, irritability and aggressiveness toward others, and failure to act in a responsible way. The worst part about antisocial personality disorder is that people with this disorder have no remorse over their misdeeds. These people will hurt, manipulate, exploit, and abuse others and not feel any guilt. Signs of this disorder can emerge early in life. However, a person must be at least 18 years old to be diagnosed with antisocial personality disorder. People with antisocial personality disorder seem to view the world as self-serving and unkind. They seem to think that they should use whatever means necessary to get by in life. They tend to view others not as living, thinking, feeling beings, but rather as pawns to be used or abused for a specific purpose. They often have an overinflated sense of themselves and can appear extremely arrogant. They frequently display superficial charm, they lack empathy, they are incapable of understanding the emotional point of view of others. People with this disorder may become involved in illegal enterprises, show cruelty toward others, leave their jobs with no plans to obtain another job, have multiple sexual partners, repeatedly get in fights with others, and show reckless disregard for themselves and others. Antisocial personality disorder is observed in about 3.6% of the population. The disorder is much more common among males, with a 3-to-1 ratio of men to women, and it is more likely to occur in men who are younger, widowed, separated, divorced, of lower socioeconomic status, who live in urban areas, and who live in the western United States. Compared to men with antisocial personality disorder, women with the disorder are more likely to have experienced emotional neglect and sexual abuse during childhood, and they're more likely to have had parents who abused substances and who engaged in antisocial behaviors themselves. Family, twin, and adoption studies suggest that both genetic and environmental factors influence the development of antisocial personality disorders, as well as general antisocial behavior, criminality, violence, aggressiveness. Personality and temperament dimensions that are related to this disorder, including fearlessness, impulsive, antisociality, and callousness have a substantial genetic influence. Adoption studies clearly demonstrate that the development of antisocial personality disorder is determined by the interaction of genetic factors and adverse environmental circumstances. And that is finally the end of the lecture. And of course, we were talking about the serial killer on Long Island, and of course, one of the aspects of serial killers, one of the things they ask you to look out for is antisocial personality disorder, obviously. Okay, well, I'll talk to you guys next week.